Hey guys, welcome back to another episode of the Vitality Code podcast. I'm Dr. Jason Farrah with Dr. Jeffrey Farrah, my co-host. What's up?
I'm riding high today. I'm riding high, Jason.
Why?
Have you?
Because you saw my pumpkin spice?
I do love. I do love the pumpkin spice. That thing is amazing. I'm a little jealous, but I know that we've never talked sponsorship, and we're not getting paid or anything. But if anybody from this company, Goat Fuel, exists and happens across this, feel free to send some free of drinks. Have you tried the Goat Fuel?
You know what? I haven't tried it, but I'm going to just say, for the sheer fact of the fact that you are riding high right now, and I'm seeing the clinical efficacy of whatever that is, I want some of that. I mean,
that's 200 milligrams of caffeine. I'm not a caffeine drinker, so that's probably part of it. But this thing has, I don't know if you're aware, but it has some mushrooms in it. Apparently, it has.
Wait a second. Well, I didn't.
Not the psychedelic kind.
The
psychedelic, right? A patient told me, like, "Oh, you got to try it. It's the healthiest drink out there. I love it. I feel so great. It's got mushrooms in it." And I drank one. I was like, "Holy!" Well, it's got 200 milligrams of caffeine, so that's there's where you're feeling your pep.
There's your pep, yeah.
But get you some acai mixed berry, and there it is.
I think producer Nick's. Sold out.
Season
3. Wow.
Well, I don't know what that means, but I do have new flavors. Publix is charging me 50 cents extra for the new flavors as compared to the old flavors.
High performance premium fuel.
Yes.
Wow. I'm
not a big caffeine drinker, but yeah, it's nice.
What a fantastic market that is. I mean, the margins must be insane.
God, they must be insane.
Everybody has an energy drink now.
Everybody.
Wait, producer Nick, can you pull that back up? What's
probably
in that
5 factories in the whole world that just make these, and they just put different labels on them.
Do you have a good name for us drink? Well,
Farrah's focused drink.
I know, yeah. There he is. I was saying, producer Nick.
But it has to be natural caffeine. I don't even know what that means. But we want it to be natural. We don't want it to be artificial caffeine,
Snow cone. Season 1. There's seasons. Wow.
Oh, I didn't know that. Don't let my daughters or the girls in my house see this. Snow cone. That's a new flavor.
Are they going to be all over it?
The females in my house are caffeine junkies. Look, it is natural caffeine. I told you. They always say that. And it's vegan. Well, hell, you should be drinking it. Yeah, cordyceps right there. Cordyceps mushrooms.
Wow.
It has to be healthy if it's vegan and natural caffeine. What else?
I bet Tim Ferriss drinks this. There's a mushroom. Hey, I got a good tip from his podcast though. Actually, there was a tea. Golly, what's the tea? I would love to promote it, but it's I can't. Apparently, I didn't drink my tea this morning.
Yeah, exactly.
But it was fantastic. It's fantastic, and I still drink it. It's a green tea, but it is awesome. Nice. And it's kind of powdered, so it's instead of it's awesome.
So, what's your morning routine? Are you a coffee guy, tea guy? You're a What is it?
I switch back and forth. I need to be more consistent.
Why?
Why do I need more consistent?
Yeah.
I think it's healthier. I think the tea's healthier.
Switch to tea consistently.
Oh yeah.
Oh, look at Nick.
That's the one. That's it. Peak. Oh, it's awesome, dude. It is awesome.
It's good taste or what?
Yeah, it's good taste. You just feel.
I love how their tagline is Tim Ferriss drinks it daily. Who is Tim Ferriss? I know I've heard the name, but I have no idea who he is.
Oh, come on. The 4-hour work week. He's an entrepreneur extraordinaire. Podcast.
Nice. He only works 4 hours a week?
Yeah.
Does he wake up at 4 a.m., though? Who's this schmo that now I see all coming across my feed? He wakes up at 4 a.m., does a reverie with his wife, walks on the treadmill. You haven't seen this guy?
They all do that.
That's true.
They all do that.
Spray cold water in my colonic and beat myself with ancient Indian artifacts
to exhilarate the chakras, bring out the line your chakras rather.
Yes.
Now, to be fair, you're an early owl. You're an early morning riser yourself.
I'm up at 4:30, but you don't know my morning routine is no influencer or no. I would have no influencer page if you watch my morning routine. I wake up and I just want peace and quiet.
Beat the children off of you.
Yes, don't wake up the kids. Somehow find out who's in my bed, which one of my kids made it in there. Get out without waking them up. Make it to the couch. Sit for 30 minutes with just peace and quiet. Read the news and then go work out.
It's like a black ops. Like it's like storming the beach. You gotta like secretly creep out of there. You're like it's a reconnaissance to find out who's where and doing what.
Because you got to keep the dog from barking. There's always a kid. It's unbelievable.
Oh my gosh! Wow.
Yeah.
Well, you got to make sure your testosterone's right for that.
That's true. That's right? True. Or else I'm just mean.
What
are you doing to my bed? I couldn't sleep.
And then the evening routine. What's the Jeff Farrah test? The bouncy the
trampoline.
Yeah, the trampoline test, baby. Is that every night? Is that a nightly thing for Harlow, or what's that?
Yeah, it would be every day if I let her. It is now because I got my pellets about a week ago. So.
Woo! Now, why did you choose pellets?
For me, pellets are right. You're like, I served that up.
Segue. I know.
Pellets are just a much better consumer option for me. I started out on injectables a few years back, and I'm a really, really high estrogen converter. It's awful. I look at testosterone and I convert to estrogen.
I can vouch for that. I remember you were telling me. Don't you remember? You remember this? Did you remember calling me about this? Oh my God, Jason, I'm sweating. I'm red. Skin's red. I can't. I'm like, dude, did you check your estrogen? Like, oh yeah. And do you remember that? It was like insane. You were having the worst reaction ever. Yeah.
Yes, I get moody. I get acid reflux.
See? Yes.
I don't really hold water, but acid reflux is my first indicator. Which then
I've never been a puffy person.
Awful. Acid reflux makes you mean and grumpy and.
Oh, it's worse. Isn't it the worst?
Yes. So that is the reason I got off injectables. I was down to doing daily injections to try to mitigate my estrogen.
Why did you take it that far? Why not just go to pellets? Did you was it hard to find a provider in your area, or what was the deal?
Yeah, good question. I probably just didn't know about it. It seemed invasive to me. You were doing them at the time. I don't remember exactly why. You weren't as accessible, and I didn't know any providers doing it, and it just seemed easier.
Like barbaric.
Yeah, and plus I had the injectables right there. I mean, I have it. It was just easier, and I was like, well, I know how to do this. I'll get it down. I was doing daily injections. Then I tried to go to daily sub-Q. It's terrible. So I switched to pellets, and it is significantly better for me, 100% better.
In what way is it better?
Well, for my estrogen production, just to give you a kind of a real world example, I was doing a 1/4 milligram of a Nastrazole every injection to mitigate it.
Oh my gosh! Wow.
Now I'm doing 1/8 of a milligram, and I'm doing that. I have specially compounded ones. I'm down.
Are you serious?
Yeah. I take a half of a fourth, so I'm down to that every 10 to 14 days.
Oh, wow. Jeez.
So we dropped significantly. And I don't have problems. I just take it because I'm like, yeah, it's about 14 days. I should take it now. And I don't run into all the side effects of
prophylactic.
And it is just a smoother delivery system. I'm also a bad patient. I say that because it's not always the easiest for me to remember my lifestyle. I'm not a regimented person by nature. I'm not a follow a schedule, have my, color-coded days. And so I'd be like, oh, crap, it's Friday. I forgot to do my shot, and then I'm dragging, and then I'm waiting for it to kick in, and then I'm grumpy Jeff, and I'm happy Jeff, and I'm, sleeping well Jeff. Yeah. And so it's easy. I just have it on my calendar. Boom. Every 12 weeks, I go get a pellet, and I don't worry about anything else. It's just much easier consumer decision for me.
Do people come into so how do you select in your patient population? You just give them the option and let them choose?
Yeah, I lay it out. So we talk about whether or not they're a candidate. Let's go through all that, blah, 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 blah. Let's say you're a candidate. All right. So how do we rectify the situation with testosterone? I said there's lots of different delivery mechanisms. There's creams, there's patches, there's nasal sprays. I don't use any of those on males. They're just too hard to titrate. They don't really work well. The efficacy rates are really low. So the two that I have found that work the best are pellets, pellet insertions, and injectables. And I go through the differences between them. I say both will raise your testosterone to a level you'll feel effect. I'm comfortable with both of them working. I'm comfortable with both of their safety profiles. It really comes down to you, and I'm going to tell you the pros and cons from a consumer decision. Now, I also say if you are a certain subset of patient, like I have some cancer patients, active cancer. Yeah, I have some heart disease patients. I have some out of the box, sort of not just run the mill 45-year-old. And so on those guys, I use pellets because I want to mitigate any potential. And the pellets seem to be, in terms of safety, there is I know we probably differ a little bit on this, but I think there's a small nod towards pellets. And how big that nod is, maybe some different practitioners, but there is a small nod towards safety and controllability with my pellets as opposed to my injectables. So I lay out the pros and cons, and then we talk about what would be the best option for them.
I think we used to differ more than we do now.
Okay.
So there, when you're saying a nod to safety, I'm going to say it confers some benefit. That's how I would say it. And with the pellets, right? That in terms of safety specifically, that the injectables don't. Specifically for those people. So the big difference is the therapeutic window and the getting into trouble is much more narrow in the injections. And somebody who has a disease process that's active would thus be at more risk. It's an additive multiplicative effect. Like, if you're a healthy 45-year-old guy who has low T and we kind of miss on your dose and we have some bad side effect, you're going to tolerate it. If you have active cancer or you have heart disease or, certainly somebody with cardiomyopathy, heart disease, some other
going through chemo. I got patients doing it through chemo.
Yeah. You don't want big estrogen and then fluid shifts. And, so you got to be really careful. And again, the margin for error is much more narrow. I agree with that. I used to think that, so it's true that bioidentical hormone replacement, so that's the bioidentical would be pellets. So pellets, I've seen their testosterone usually from wild gams. They crystallize into a pellet about the size of a Tic Tac or a grain of rice, I've heard, but it's more of like a Tic Tac in my eye. And it's the crystallized testosterone is bound together with, I've seen two ways, cholesterol or stearic acid. Is that what you?
Yeah, I try to primarily use the cholesterol. Again, just a nod towards the bioidentical. If we're going to do it, let's just go all the way. There is some talk amongst practitioners. I don't think I've ever seen any white papers, but I teach for a pellet insertion company, so I do pellet insertions all over the nation. But there's a common talk amongst practitioners that your extrusion rates and your efficacy rates are better with the cholesterol.
Oh, really?
I've never seen a white paper, and I don't know that to be true. But sometimes there's a thought that the stearic acid may be rejected by some people's bodies, and your extrusion rates could potentially be higher on that.
I've seen published case series. I think they're case series. There was no randomized controlled, placebo-controlled data, but it was a case series, and I've seen a couple of them, 2 or 3, looking at extrusion rates, and the common denominator was infection, is what I've seen. I think that device, by the way, is superior to the Pelcom device. I think, and I agree. Now, there's a lot of people that do pellet insertions. I don't know what percentage of those pellet insertions are classically trained, broadly experienced trauma surgeons. Surgeons in general. I did a residency in general surgery, fellowships in trauma, critical care, and emergency general surgery, and then have been attending post fellowship 10 years. So I bring that level of expertise and experience to the table, and then analyzing that device and the way it interacts with human tissue is superior to other methods. It has a lot of those
little small safety features to it that allow for depth of insertion that are nuanced but important.
That's important and huge. And then also, I find the way that Pelcom calls it the needle, but that little trocar, the way it's shaped, the way it passes through tissue, it creates less damage.
For sure. And it seems so simple, but you're like, why didn't I think of that? Or like, why was I doing it that old way? That old trocar. So let's explain this to patients. A pellet insertion is a subcutaneous. So in the fat, we place under the skin in the fat above the muscle. We insert testosterone, powdered testosterone, compressed into a Tic Tac would be a way to think about it. They're white, and we place them under the skin in the fat layer, and they slowly, we'll just say dissolve. They slowly dissipate over the course of time, and they deliver your testosterone that way. And so you are making a small incision, and you are placing the testosterone in the body in that little fat layer. And so there is a procedure that is involved in that. And the old device, it was an 11 blade, I believe, and you free cut your incision, right?
Yeah,
so,
right, yeah.
Some doctors were more, I see this because I've trained plastic surgeons, I've trained orthopedic surgeons, I've trained aesthetics, I've trained primary care, and there's a real difference in how they make incisions, right? I've seen trauma surgeons.
Well, I mean, I know, but have you seen differences among the specific surgical specialties?
110%.
It's so funny, huh? That's very interesting.
By and far, which makes sense, plastics are the best at pellet insertions.
Absolutely, I'm sure.
They just have a nod to understanding that, again, because they're dealing with the way it looks all the time, right?
The finesse is probably way.
Yes.
You wouldn't want to put a plastic surgeon in a person with a gunshot wound to the belly.
Correct.
And a belly full of blood flowing at him. But yeah,
when you have time and you can set it up however you want, and you
don't want a trauma surgeon fixing your face, like doing your facelift, and there's a reason. Exactly.
Yeah. But it just makes sense, like you said, you're dealing with gunshot wounds, and time is of the essence, and a plastic surgeon's like, no, we're scheduling it on this day because the moon shines a little bit different and it pulls they just think about it that way.
The priorities are different.
Yeah.
Right. The priority is not on the aesthetic or the beauty or the finesse. I mean, there is certain finesse in certain ways, but just a different. Yeah, it's just
different approach.
Different, yeah.
So.
But the plastic surgeons are more meticulous and
more meticulous.
Yeah.
But it's been 50-50 on surgeons, and in the beginning I had a bit of imposter syndrome. Here I am, which I would, I said just a primary care sort of, teaching a surgeon how to do a quote unquote, not surgery, but surgical process to a certain degree. And I had a sort of, inferiority complex, but I found 50% are like, I got this, whatever. Just yep. Okay, I'm good. You can leave. And then 50% are like, no, I want to know the nuance. I want to see this. Show me how you keep sterility. Show me how you do this. And so
does that vary by specialty too?
No, at least I haven't noticed it. It seems to be practitioner, which I was shocked. Like some practitioners are just very nonchalant, and some practitioners are just like, I'm pretty strict on my sterile, and I'm pretty strict on all that when I'm teaching people. But I had one surgeon, I can still remember him to this day, and I've never seen anybody be so concerned about sterility to just, in a good sense, like he made sure all his staff were understood the utmost importance of sterility in this procedure. And I imagine he carried that to all his surgical procedures, and he just stand out above everybody else. So there's a wide array of how people approach sort of procedures and medicine in general.
But you would say that same difference appeared within the different specialties. Like there was plastic surgeons that weren't so, and there were plastic surgeons that were so.
Sure. Whatever. Surgeons in general, some were, some weren't. General practitioners, some were really good and some were just shaky and had never held a needle and done, had done anything. And some were naturals and really good. And some were more concerned with specifics and details, and some were not. Yeah. Big, wide array. I think I have been shocked. The longer I'm in allopathic realms of medicine, as a non-allopath, when I began as a chiropractor, I just assumed there was this strict algorithm that they all followed, right? And I'm going to say it's not that way. There's a huge individual difference in the way medicine is practiced between practitioners.
Yeah, I agree. So when somebody comes for a pellet, what are they going to experience?
So a pellet procedure takes, I tell people if we don't chat, which in my office we generally do, but if we don't talk, you're in and out in 10 minutes, from start to finish. But so what we'll do is we set you up, and we're going in sort of what people would call their hip region or their upper buttocks, glute med region, if you have some anatomical knowledge, kind of your back hip pocket. We'll clean you. We'll sterilize it. We'll anesthetize the area with some lidocaine mixture, and then we make a small incision, and then we place the pellets up in that outer region of your hip in that outer pocket. No stitches, no glue. We strip you up. We put a compression bandage over it with a nice waterproof, and then you're off to the races. Takes a few days to kick in on your first insertion. I tell people within a week you wake up and you feel nothing on your first insertion, then we're right on track. And then day 8, 9, and 10, someone else says something to you like, "Oh man, you're acting different. Like, what's going on? Things look, your outlook's different, or this is different, or you're this." And then you're like, "Oh wait, that pellet is kicking in," right? Because it doesn't make you who you're not. It doesn't change you into somebody new. It just changes you into somebody you kind of forgot that you were, right? So I always tell people, you may not realize how lethargic you've gotten. You may not realize how bad your mood has been. You may not realize how bad your brain fog was. So when it all comes back, you're just like, no, I've always been this way. And in actuality, someone else is like, yeah, you're being really different and in a good way. And what's going on? And you're like, no, I've always been this way. So it kind of kicks in. You have
that phenomenon where you notice things about the patient when they come in, even the way they come in, even the way they walk through the door and talk to you. Yeah. Mm-hmm. But they don't even realize it. Yeah.
They just hold themselves different. Their face looks different. Their conversation is different. Yeah, their affect is different. I'm like, hey, you're feeling good, aren't you? They're like, yeah. How do you know? I'm like, so yeah, for sure, you see that.
So I think this is an important thing to talk about. What are your landmarks, your anatomical landmarks, and what is the zone or the triangle? You kind of mentioned it, but the reason I ask is I recently had a couple come in and they had both received pellets. The guy specifically, was awful procedure, painful, where he had it before, and his scar was, I want to say it was like above his pelvic brim in the back. Like it was like,
love handle region. You mean?
Yeah, but more medial.
Oh, medial. Yeah.
I was like, what in the world? Like it was where the back of your belt would be. It was like great in the belt
SI
line.
Joints.
Yeah, I guess like almost superior to that side, or like the superior part of that side. I was like, holy mackerel, what in the world happened here? So tell people what are your landmarks?
So I tell people, a tough insertion is a lean male that has body mass, because a lot of times pellets, for males specifically, the amount of testosterone, i.e. the amount of pellets they're receiving, is direct relation to a large part to their body mass. So if he's lean, i.e. doesn't have much fat, not much place to put it, but he needs a lot of pellets, he's going to be sore. So when I'm teaching practitioners, I tell them we want to go high and outside is generally the sort of thing to think about, right? So I tell people, take your middle finger, you put it on the patient's ASIS, and you put your thumb facing the top of their gluteal cleft, i.e. their butt crack, and right in that region of the web of your hand where it's most likely going to go. And then we put a dot, and then we step away. And it shouldn't be in where the glute maximus starts to make the beef part, the bubble butt, if you would, if you had a really big butt, right? Where you can start to see the glute maximus come into effect, because then they're going to sit on it all day. There's a lot of hip action that happens there. You want to go superior above that.
Yeah, you do.
And you want to go out in that glute med. So you always want to go high and outside. Whenever I see practitioners make a mistake, they tend to go too inferior or too medial towards the SI joints. And then patient sits on it. There's a lot of motion there. Nothing's worse than sitting on a pellet insertion for 3 months. It's terrible, especially if you're a lean guy. Females, they tend to naturally carry their fat in their hips, and the pellet device is much thinner, and the pellet volume is significantly less. So generally speaking, you still want to go high and outside, but less of a problem. But pellet insertion is it's not like complicated, but there is an art to it. And I think a lot of people who have had pellets and have bad experience had a bad practitioner, if you just want to be honest about it.
Or inexperienced, or just
inexperienced.
Didn't get good teaching or something like that. Yeah.
Or just didn't think about it. Right. I think because I'm getting pellets, I'm a leaner guy. If I, and I take a decent amount of pellets, if I have a bad insertion, I'm like, dang it. Now I'm sitting on that thing for 3 months. It's awful. It's, and I don't like it. And it bumps on everything when I drive. And so it can be a problem. So I think placement is key.
Yeah, absolutely. I totally agree with that. And, you're doing this all around the country all the time. So, I think you got to be just de facto, you gotta be one of the most experienced people out there doing it. I mean, just because
I don't know what rate of number of pellets. I think I've seen the most variety of practitioners, and there's a difference between doing and teaching, right? I had to get really good in explaining and doing it and understanding it to teach other doctors. The thing I also really like about teaching is the clinical support that Pellet provides. I participate in that. So I get to hear a lot. I tell people I get to hear a lot of mistakes and workshop those mistakes without actually having to make those mistakes. So it'll be like, well, what happened? What's going on? Why did it happen? Oh, this is how we should have handled it, yada, yada. And I didn't actually have to make that mistake to learn from it. So I've workshopped hundreds and hundreds and hundreds of mistakes without actually making those mistakes. And so I'm like, sometimes you're like, oh, I never even thought that was a thing. I'm going to make sure I don't do that. So I preemptively learn so I can really mitigate issues. I feel like it's really helped me mitigate issues prior to them actually happening in my practice.
So is there anybody that you have ever had in your clinic, speaking about pellets, and, if people are thinking, am I a candidate? Has there anybody based on anatomic reasons, thinness, skin laxity, collagen, thinning or loss of collagen rather. Mm-hmm. And what I mean specifically, so let me tell you the context. I had a patient who had been on steroids for lots of years due to Crohn's, bad Crohn's, multiple surgeries, tons of surgeries.
Steroids, not anabolic.
Thank you. Corticosteroids, prednisone. That's a good point. And also had a lot of muscle loss in the hip and glute region.
And probably tanked his testosterone because corticosteroids do that.
Well, as a female, but and she did. But I thought about it later, and I was like, you know what? I think in the future I'm gonna maybe stand people up, have them drop their trousers and take a look, feel the skin, touch it, because when it's stretched out too, it's different, and when it's not, and assess them. And maybe there's people, I've just haven't run across a lot of them, but this one was definitely, I was thinking, in retrospect, I don't know if they had their epidermis, dermis, and even their subcutaneous tissue. I don't know if it was really the best to accept a pellet load. Now, in a female, 1 or 2 pellets, and the second pellet's usually a tiny little thing anyway, not as big a deal. But if had this been a man, there's just no way. So do you ever have people you're like, I don't think you're going to be a candidate for pellets based on anatomic reasons? Do you ever find that?
I haven't run across a yes or no. I've run across guys saying like, hey man, you're 6'3", 260, you're super lean. We don't have, you're going to be sore tomorrow. So you need a lot of pellets. You need 9, maybe 10 pellets, and there's not much place to put them. Just be aware. And these tend to be people who work out a lot. And so I will actually, I have a couple of people I'll stand up. I'll put where I'm going to do the pellet insertion, make my tracks. I'll have them stand up and I'll have them do a squat, and I'll see if that region bends and flexes with their squat, because I don't want them going to the gym. And I don't, so I want to make sure I'm above that so they can know they can do with the things they do. We are in rural Florida, so there's some people who do horse riding. That was a new one. I'm like, don't horse ride for the next 3-4 days. Right? You're just bouncing on that saddle.
Know, yeah.
And even in Western saddles, the difference between a Western saddle and an English saddle sometimes is where that cups you in the back. And so you get a more full seat with a Western saddle. So it could potentially press up on a high outside region.
I never thought about that.
Yeah. So there's all these little weird, instances. But I haven't had anybody that their anatomical can't handle it, but I've had people like, this is going to be sore tomorrow because you just don't have any fat.
The other thing too that I run into is at the lower bound of the anatomic region, there is that bubble or the bend in the gluteus that you have to be aware of, that you wisely talked about, and you're absolutely right. It's more painful there. You're sitting on it, that kind of. But going up and even maybe medial, and you don't want to be too medial by just anatomically and a lot of reasons why. But one thing I run across is where women might wear their thong or their panty line, and that's also irritating. It's having a pellet right there where it's rubbing on that, or it's worse to sit on it, I guess. So sometimes it's like you're in this tight spot because you don't want to go too low because of the first reason you said. You don't want to go too high because you don't want to be on their waistline, panty line, where they wear their belt, where they wear their pants, and there is an art to it.
There is, for sure. For my females too, is, we're in Florida, so I always make sure I stay in white, meaning if it's tan,
that's a good point.
It's probably getting exposed to sun, and they don't want, one of the big differences between the Pellet device versus the other is the amount of potential scarring. I have some pictures in my phone. I see a bad examples from the old device. Is you don't want any scarring, and you shouldn't run into that at all. Should not be high extrusion rate. But you stay in the white, and so their bathing suit is going to cover it there. Their underwear is going to cover it there. It's just much safer.
So that's interesting, because I've also had the thought too that a woman had coming back from Spain, and she was tan, and the white part was where, like you said, was where the bikini had been. And I asked, what kind of underwear do you wear? Is this, she usually wears thongs or high rise, I guess I don't know if I'm terming it right, but panties. But basically that's her panties went in the same spot, the white. So she was not going to be in the sun anytime soon for months. Not like she had just, again, come back from an older woman, come back from Spain. So I actually chose the tan, not the white, because I didn't want it to be rubbing on that part.
On that tissue.
She had no desire to hide it per se. So I guess it's, I think the point is it's very patient specific. But I guess in what you're saying is rather to have potential irritation but be covered than to have it exposed and be a scar area that you don't want to have.
Yeah.
Then be subconscious.
Again, the pellet shouldn't scar. I tell everybody they should not extrude and they should not scar. As a practitioner, your extrusion rate should be 0 for females right out of the gate. You should strive for a 0 extrusion rate for females extremely quickly. There's no reason. If not, we need to clean that up. For males, it will hover around 1% to 2%. Probably for the lifetime of your practice. You're going to have one extrusion a year, I think. But if you're pushing up to 10%, 7-8% of extrusions, then we need to clean up some practices.
I've not had a knock on wood. I've not had a extrusion rate since switching extrusion myself, me personally. Maybe somebody else in my practice, but I have not had one. And knock on wood, I don't think I've had a single one.
Yeah, I had my first one of the year just happen for a male. And
really?
You're like, drives you nuts. You're like, I was doing so good, and there's some factors, and we always try to find out. But I'm always, did I do something? Did I clean it up? How should I do it? Things like that. And your infection rate should be 0. That is bad practice on your part. This is what I tell my practitioners. You should really clean up if you're getting infections. And an extrusion is not an infection. We're diving into practitioner stuff, so maybe not appropriate for general populace. But you shouldn't get infections. General population, you should not get scarring. You should not have giant bruising. I've seen bruising that looks like a damn hip replacement.
Now I have had people with bruise on me. What do you think's going on there?
I think it's for most people, we're excluding blood thinners or aspirins or 2 bottles of wine the night before. But I think the old device was really prone to a lot of trauma. That cutting style of that, I call it a spear, where you were sort of like tunneling through the tissue, was super traumatic, right? Versus a scalpel to edge. So it shouldn't. I don't know what leads to more bruising. Maybe a little bit of epi. Maybe they didn't use epi. Maybe in a rush. You know what I mean?
Maybe wrong plane or sky the muscle.
Yeah, sometimes you get a little too deep and you can get near that excessively vascular area. So I really try to be. I don't think I get much bruising. Sometimes you will, but sometimes it's just the way it is. You are cutting through tissue.
Right.
But it shouldn't be scar tissue, and you shouldn't have scars externally.
So one of the things I've heard arguments against pellets is that they're constantly pouring into your system, and it's not pulsatile.
Yep.
And the case people were making was that injections were pulsatile, and that's true and not true to me. As somebody who studied wound creation and wound healing, the natural history of it would be that you would kind of have an encapsulated area, a network of capillaries with the healing, would come around that, and it should leach out. It makes sense. I'm not seeing any. I can't recall seeing any studies.
Hour by hour studies. Yeah.
Yeah, but it should. If the cardiac output's increased and the blood flow is increased, you should have more leaching out. I mean, that makes sense physiologically. I'm not seeing any proof of that, proof of concept per se
Sure.
in the data. Now, it may exist. I just don't know. I'm aware of it. Are you aware of it? I don't know of any.
I'm not aware of it. And I've had patients ask me that, and I say, yes, but let's not forget what we're doing here. You're taking an external source of testosterone. So natural's out the window.
Natural's out the window, exactly.
I'm not a fan of this natural. You're eating strawberries in December. That's not natural. You're flying that in from Mexico. You have 24/7 access to fresh fruits and vegetables. And no one's ever you should only eat fruits and vegetables during the spring and summer when they naturally bloom in the region with which you live. You live in air conditioning 24/7 and heat climate control. That's not natural. You drive a giant 3,000-pound automobile with analog brakes and systems and Wi-Fi to work 40 miles away. That's not natural. So at some point, there is a level I think we need to probably strive to, but we don't say, well, I'm not going to drive my car because it's not natural. We say oh, that's acceptable. There's a danger to being on the road. There's a benefit achieved from being able to get places and across the country and with ease. And so that's an unnatural thing that I'm willing to take on.
Right.
And I think that for me, I don't think that injectables being more natural is a valid argument. I haven't seen anybody hold water with that.
It can't because even if you conceded that, yeah, that's what it is. So you're telling me the body only puts out 2 pulses a week,
yes,
2 peaks a week. I mean, no, it's a peak in the morning, right?
Well, which is why the injectable, with last episode we talked about, the nasal spray was 4 times a day. They were trying to get more towards that natural, but I'm like, that's not practical. Maybe natural, but it's not practical.
If you had to think about breathing every second, every times, or 12 times a minute, you couldn't do it. If you had, so that's what you're saying. You're saying that throughout my day, I've got to mimic what is under, control of my brainstem, and hypothalamus and pituitary, and I'm going to now put that responsibility into my prefrontal cortex and my conscious thought to spray this. That's not natural, right?
Right.
I think you got a good point there. It's out the window. So then now, if you're doing injections, what's that like for somebody?
So
where are you giving them? What are they doing?
The juxtaposition is that you're doing them. I prefer them in the hip. As long as they're intramuscular, it's fine. I don't think there's any benefit to going sub-Q. There is some people and some, different absorption rates. I do IM. I do same kind of place you would do a pellet insertion, top hip corner, upper outer corner
the buttock,
of the glute med. You could also do the front of the thigh, upper outer. I always tell people, if you took your butt cheek and you divided it in fourths, go the upper outer quadrant. If you took your thigh, the front of it, and divided it into fourths, go upper outer thigh. The back is such a big muscle. Your glute is such a big muscle. You won't feel that injection with a tiny 25 gauge needle. And it can accept any amount of fluid that you put in there for a normal injection size. It can sometimes be kinesthetically hard to get back there for some guys and mobility wise. So sometimes the front of the thigh makes better sense.
Exactly. So I was going to say, that's where I was going to say. I was going to say, now here we go to the practical issue again. Sometimes it's very difficult to turn, give it, and make sure your angle's right. And whereas if you're doing it in the upper outer thigh, away from neurovascular structures, that's why we're doing it there, into the meat of the vastus lateralis, or, you picking it up, isolating the muscle, putting it in. It's just a lot easier sitting down doing it.
Yeah. The easiest is if a spouse will do it or somebody at your house will do it for you.
That's true.
Always clean the skin. We teach people how to do injections. So there are some clinics, a significant amount I've found that you have to come in and get your injections. That just seems to be onerous for me. Like, you have to drive to the clinic twice a week. And they're like, yeah. Or I'm like,
but what? Some people like that. I have some people that would prefer.
Yeah, I do have a few. It's just easier for them. They're just nervous. They're going to mess it up. Right. I would say 90% in my clinic don't do that. We teach them. It's controlled. You can only get some people, doctors are like, well, they're going to do too much. I'm like, how? It's controlled substance. I'm calculating your dose. I'm sending you a 84-day dose, and you're not getting any more until day 85. So theoretically, in that first
if you
window,
decide to do that, then you are gonna. You won't get any on the back end. Then
yeah, and it's controlled. So here's the other thing I tell patients is your script is in the national database. So if you're gonna doctor shop, you're gonna get caught. I've had one patient, and I fired him immediately.
Yeah.
I was like, "Who's Doctor So and so and so?" And I called the pharmacy. I'm like, "Don't dispense that I wrote a script, don't dispense that, and they're like, yeah, we see that too. And I called him up and he was like, hey, well, I was down here and I just thought it'd be easier if I get it from both people. And I was like, why don't you just stay down there? So, you can 100% teach people to do their own injections safely. I've never had anybody have significant
lateral
issues.
delt. Do you put anybody in the lateral delt?
I don't like that. I don't know. I don't know this to be true, but I tell people it's easy for me to do it there because you don't have to take your clothes off. You don't have to do anything, but it hurts. It's a small muscle. So it's not the needle that hurts. It's the fluid, and it's just a smaller muscle. And it doesn't feel good. But you can 100% do it there. And it's also not really kinesthetically any easier, I think, to get to your delt. I think the thigh is the easiest.
Do you do, now speaking of different delivery methods, and I know we're kind of focusing on the two major ones here, and of course we've said in previous episodes that there is the bioidentical gel and cream, but do you do Clomid on anybody? Clomid?
I do.
Yeah.
So
there's good data out of Mayo Clinic that works. Yeah.
Yeah, I do Clomid. I give everybody an option. I say, is fertility a question for you? Is there any? And I usually phrase it this way after talk about the pros and cons. I say, what if you wake up 10 years from now? There's no data to suggest this, but let's assume worst case scenario. You wake up 10 years from now, you're 55, and you decide you have a new wife, you want a child, she wants a child, and you want to do it. And because of testosterone, it makes it really difficult or you can't. How would you feel about that happening? And if there's any pause or any, oh God, I never thought of that, well, then let's protect your fertility and where's your risk tolerance? And so I do Clomid on my younger guys. They tend to respond better, in my opinion, to Clomid. They'll actually get the raise in testosterone along with protecting their fertility. Some guys are on Clomid only.
Yeah, and that makes sense. If you think about the analog would be the ovary. And one of the chemical signs of ovarian failure, i.e. menopause, specifically as an FSH, was it greater than 20 or 30?
30.
It has to be 2 times 6 months apart or 3 months apart, something like that. So the point is that the pituitary gland and the hypothalamus are cranking out more stimulation, i.e. Clomid. We do the same thing, but now there's no response from the gonads. So it makes sense that it would work for a younger guy because there's still that responsivity there. Just I
tell my older guys, like if you're 45 and you could have a child who's a De Niro or somebody had a child at 77, you probably, the reason you're here is that the gonads aren't operating optimal. So me stimulating them won't make them probably not overcome the suboptimal performance. But what the Clomid will do is protect what you have from potentially being shut down further. So we can run that concurrently with your testosterone. So I use Clomid 25 milligrams Q Monday, Wednesday, Friday. And kind of that's my basis. And I go from there, maybe daily, maybe 50 milligrams, depending on the response and what's going on.
Some data I saw out of the Mayo Clinic, said that the 25, this was a cohort of younger guys, under 40 or under 45. Actually, they had a better response and more satisfaction with the lower dose, which was, again, it's not always the case that if some is good, more is better, right?
Yeah. So I suggest, pellets versus injections, which we kind of talked about. I have some younger patients who are still in the childbearing ages, and I am all right doing pellets on them because I just had a gentleman just recently and wanted to have a child, and we ran Clomid while he was on his pellet. When that pellet wore off, so to speak, we added some HCG. His testosterone with Clomid HCG came up to a nice, good level. His wife got pregnant. We reverted back to the pellets. And all was good. So I think even with pellets, you can use those two fertility protection methods.
And I tell patients too that you don't have to have a testosterone of 1200 to get somebody pregnant. The HCG, seriously, because the HCG is stimulating the Leydig cell, whatever you want, however you want to pronounce it, in the testes, and it's the intratesticular testosterone that creates the maturation and stimulation of sperm cell growth. So you need the testosterone within the testes, the intratesticular testosterone to be high. And then the byproduct of that is that your serum testosterone should be higher. But so that makes complete logical sense. Hey man, so I guess last thing I'm thinking is, how do you know which one's right for you?
pellets or injections?
Yeah.
I tell them it's a consumer decision. I lay it out like this. I'm like, let me just lay out some scenarios for you. Like, do you travel a lot and find yourself across country and you travel for your job, and traveling with some needles and vial of testosterone sounds terrible? Yes or no?
It's difficult.
Are you a good patient? I tell people I'm not. I just I know myself, and like, are you pretty regimented? Like having a your anastrozole might be once every week and it's on Wednesdays. That's hard to remember. Do you have a pill tray? Could you get one? If that sounds terrible to you, then maybe you're going to lean towards pellets. I tell people pellets are a little more expensive in my office because I'm doing more of the work, and injectables are less expensive. You're doing more of the work. Which one of those sounds better to you right now? And then I say, are you looking for optimal? I want the best of the best. I want what that is important to me. Then we lean towards pellets. It's a consumer decision. So we start to lay out some of those kind of things. And you're not pigeonholed into one or the other, right? You can switch.
Switch anytime, yeah.
Yeah, so there's no great algorithm. This is another thing I think doctors and patients get confused. Like, well, let's start out on injectables, see where I need to get, and then you know how much pellet to do. It doesn't work that way. Right?
Yeah.
There are different delivery mechanisms. There's no algorithm that says, oh, you're on 200 milligrams of testosterone, you'll be on 1,200 milligrams of pellet.
Right.
The pellet is a good, safe option. I like it because you're just stable. For the practicality of it, it really fits my life. So I don't have to think about injections. I'm just Jeff. I'm not high or low Jeff. I don't ever worry about, maybe I'll do a little bump now or this. And I've had some patients. I just had one recently in the last month, and he was on pellets. And he's like, I want to give shots a try. My buddies are all on shots, and I'm going to do that. It's a little cheaper. And about 4 weeks later, he's like, I can't. I keep missing it. I'm just, I can't remember. I'm traveling all the time. I don't want to be that way. I don't want to think about it. Right. I've gotten too busy. Right. And so he went back to pellets. So I think it comes down to a consumer decision is what I tell most people. Saying we're taking the outliers out of it. You're not an active cancer patient. You're not significant liver disease. We can, either one of those is medically okay. Then it's a consumer decision. Which one of these lifestyle factors makes a good choice for you? That's how I tell patients.
I think that's fair.
Yeah. And the pellets are safe. I mean, everyone wants to know where they're made. They're made in a pharmacy. They're sterile pellets. I've never had a problem with them.
Zero.
In terms of, it's a pretty standard procedure, but you got to make sure you're getting them from reputable people. I don't know if I've never heard of it. I think I have access to a wide variety of practitioners doing pellets just because of the nature of my job. And I've never seen like, oh guys, stay away from that pharmacy. But they're pretty safe. And I think also you'll see something change in the next 10 years where maybe we could get them to last a little longer. Maybe the new technique that we haven't even thought about. That's been a conversation between me and you. What if you could do a year pellet? How cool would that be, right? Maybe you start with 2 insertions at 3 months to see how they feel, and everything's good, and then you go to a year pellet. I mean, it's a consumable capitalistic market, so the more people that are doing it, someone will change the industry. We couldn't ever thought of. Yeah. So that would be really cool.
Yeah. I agree. All right, my man, this has been good.
Yes, sir.
I feel like, we've given people a good amount of information there to help be able to decide, between the two, which is the best for them, and at least to facilitate a discussion with their qualified
ask your practitioner. Do you do pellets? And if you don't, why don't you? And if you don't do injectables, why don't you? And let's talk about what's best for me.
Yeah. All right, my man.
Don't forget,
next time.
Go
Fuel.
If you're listening,
I'm gonna go get some right now.
Try some. Get the acai.
Is that the purple? The acai?
Yep. Yeah. And then also gummy bear. If you like the really sweet ones, it's called the flavor is actually called gummy bear.
How sweet is that acai?
Not as sweet. The gummy bear is like, it's like holy sugar. Yeah,
have you ever had Alani? Have you ever had the Alani?
Yes, I don't. Those are too sweet for me.
Is it like that sweet?
The gummy bear leans towards that. Yeah.
Yeah, I think I'm gonna go with acai.
The Alani, I feel like I'm like Kim Kardashian when I'm drinking it.
Do you drink with your finger out? Like,
it's not a monster. I'm a man. Give me my damn Red Bull.
All right, my man. I'll see. Hey, I'm gonna get some Go Fuel right now.
All right, see you, brother.
See you, man. Bye.